Cancer Manager for this area in the Integrated Care Board. So I'd just like to welcome you all this morning for this education event that Joyce has very, very meticulously planned for you all. So I hope you get something very interesting and useful out of this day. Just a bit of housekeeping. There is no planned fire alarm this morning or this afternoon, so if it does go off, we can leave the room by the fire exits in this room, or out the front door. So I will pass over to Mark, our first speaker of the day. And just to mention, we are recording the event just for reference, but we're recording from the back, so we won't do it from the front. So just let me know if that's a problem for anyone. Okay, so over to Mark.
Woo! Okie dokie, thanks very much. I'm guessing I won't need a microphone. Can you hear me at the back?
Yeah.
Very good. Yeah, the big booming northern accent really works for me. So I'm going to talk to you, and I'd like to join Vicky in welcoming you to the day, and thank you all for coming, and to thank you to Joyce for inviting me. It's a real pleasure to be here. And also I get to also thank you for coming and to introduce the subject. So that's all good. So what I thought I'd talk about, and indeed what I've been asked to talk about, which is handy, is why is personalised care important? And some of that is, well, I've tried to make it a less personal sort of view and more of an evidence-based thing. So hopefully that will be helpful, and that will lead into the rest of the day. So I'm a very informal presenter, barely a presenter at all. So if you do want to ask questions, just jump in with random or whatever. Or if I say anything that sounds ludicrous, feel free to jump in and disagree with me. I like that now. Okay, so why personalised care is important? Okay, so I'm going to talk about what the different elements of personalised care are, and some of the evidence base for these. And to be honest, there's not a great deal. There's some areas of personalised care are covered better than others. I'm going to talk about that a little bit. Why delivery is important, some of the challenges, what to do, and what we need to deliver. Because the other role that I have, as well as being Macmillan lead cancer nurse at the Royal Berks, is to lead for personalised care, one of the secondary care leads for the Thames Valley. So I do lead with that. So I'm fully aware, and many of you will have seen me on meetings if you attend the sort of personalised care forum meetings about what we have to deliver. And now I'm going to try and summarise that a little bit, if that's all right with you. Okay. So this is a very handy infographic, and it saves me being too boring just to tell you a big list. So this is like the experience of patients, sort of increasingly, and there's genomic testing right at the start of that. Many more and more people have that, certainly in things like Lynch syndrome, gynecology, colorectal, certainly in skin cancer. There's lots more genetic and genomic testing going on, and that's part of the whole of the personalising the agenda to individual patients. Holistic needs assessments, you'll all be pretty much familiar with them. Can I just say, is there anybody who isn't at all familiar with personalised care pathway in the room? Don't be afraid to put your hand up. You don't work in cancer like that. So I'm probably teaching my grandma to suck eggs here, but I'll continue. The holistic needs assessment, normally what we'd like to do is to give people holistic needs assessment close to diagnosis, and then at least another one at the end when people are discharged, or either discharged or onto sort of open access follow-up or PIFU or whatever you want to call stratified follow-up programs. I think it's really important that those are done, and that care plans are linked to those. Those care plans should link to what the patient's needs are, and then those are, generally speaking, shared with primary care. So those of you who work in primary care should be seeing those, should be able to see those holistic needs assessments. They should be able to see the care planning, and therefore that should help you in your work in trying to support patients. That's the way it should work. Obviously, there's many different systems involved with this, and sometimes those systems don't necessarily talk to each other brilliantly. So you might find that we do lots of, obviously we do holistic needs assessments across the Thames Valley in about 70% of our patients, and therefore you should be seeing that in primary care. I'm guessing that you don't all see that, so that would be disappointing. We're trying to work on that, and what the facilitators have done in the last couple of years is trying to improve that. So Joyce, I think we'll be talking about that, the team will be talking about that later on, so that would be really good. The next bit that you should get, and this tends to be linked to sort of stratified follow-ups really, is a treatment summary. And those where we've got areas, for example, breast cancer, and Catherine Bailey's here as a nurse consultant with Royal Barts who sort of like have oversight of the breast stratified follow-up. All of their patients, for example, get end of treatment summary, and that's shared in primary care as well. So you should be able to see that. Patient sees a very much personalised version of that, and an easy read version of that, and there's also a more technical version which goes to primary care. So I think Catherine will be talking about that later too. So that'd be good to see what you think of that. We should get a treatment summary, and sort of at the Royal Barts, I can speak to pretty much all of our breast cancer patients. Well, all of our breast cancer patients, all stratified follow-up, get a treatment summary, and increasingly colorectal will get that as well. So you should be seeing those treatment summaries come through for those groups of patients. Following that, and this is sort of Joyce and the facilitator's main body of work, is trying to link that up to cancer care reviews. So back in primary care, we should be able to locate patients who have finished treatment and then provide them with firstly a more brief sort of catch-up around their cancer, and then a more formal cancer care review later on. So those should all link up with the previous information you've had. Obviously, health and wellbeing support we've done quite well at over the years, provision with things like virtual sessions around health and wellbeing, in person, increasingly in the post-COVID world, increasingly in person meetings where people can get together to talk about their health and wellbeing, what's provided, dietary requirements, support that's available in the community, what we can offer you, and also sort of what patients, and also things like facilities that might be local to them. So we've done quite well over the years, and that's something that's quite research proven. The other thing that covers all this is stratified follow-ups. Increasingly, as I'll talk about later on in the presentation, the more traditional way of following patients on, where you go and see a doctor every 6 months or every year, doesn't really work. The reasons why it doesn't work are there are lots of things in that meeting that aren't included, it's not very personalised, and what we tend to find, and this is research proven, is the fact that patients tend to wait until their next doctor's appointment to report, say, a breast lump, which is like counterintuitive. If you want counterproductive, if you want people to report, and we find that stratified follow-up programs are actually better with that than more traditional follow-up. The other thing, of course, traditional follow-ups sort of quite a lot of resource for very little benefit. So that's where we are. Any questions about that? Yeah, hello.
Sorry, I thought I was familiar with the pathway, but I realise I'm not. So stratified follow-up, does that mean that the patient will then contact you if they've got different needs?
Yeah. So what we do is to provide patients with information on, say, red flag symptoms, and if those red flag symptoms, we make sure that before we put them on the program, and we have an easy way back in to the system. What we don't want to do is say, go over there, look after yourself for a bit, and then they can't get back in. So we make sure that that we can get people in very quickly, and that tends to work well. So again, you're absolutely right. We're expecting a degree of self-care there, and education. The other thing is that how stratified follow-ups work, different tumour sites, there'll be different elements. I mean, the breast sort of stratified follow-up, there's still quite a lot going on. There's like mammograms, there's DEXA scans that have to be done at set times, and they're all we're sort of managing that really all the time, and there's equivalent colorectal, prostate, endometrial cancer. Well, endometrial cancer, not too much, but there is a bit. Okay. Any more questions about that? Everybody get that? Anybody troubled by that? Good. Okay, so what is the evidence to support it? Well, I thought I'd work through this a little bit. So, in terms of H&A care planning, once again, there are bits of this. H&As have been around longer, actually. Started about 12, 13, 14 years ago. I did a pilot scheme around that length of time ago. And there was, and we can see that it's cost effective in women with gynecological cancer. It improves, and this is sort of research, quite a large study, improvement in functional symptom scales. Evidence supports integration of H&A into a multidisciplinary process of patient-led healthcare. So it does work. But what we've found recently, there's quite a bit more research which seems to indicate it's not, because we tend to be, certainly all cancer alliances tend to be obsessed with the overall numbers, but what we're finding is that it's the quality of those that's important, less the numbers, more the quality. And that's something that is quite important. So if it's like a box ticking exercise, patients notice that, but also the quality of those reviews won't be as good. That's my experience too. That if you're doing that as well, because someone's told me I've got to do it, it's different from actually engaging with the patients. So that's what research has shown. Certainly there's a big study by my friend and colleague Campbell, who works at Napier in Edinburgh, that shows exactly that. That if it's the quality and the outcomes that are important with H&A rather than the absolute numbers that everyone's got to have. That's interesting. Treatment summaries certainly positively evaluated by both GPs and oncology clinicians when it was originally launched. Very little research ongoing into that, but certainly the most recent research I could find that patients receiving SACT particularly positively evaluated any treatment summaries and found it useful to have their version. So that's got some research back up, but obviously a little bit more work needs to be done. Cancer care reviews, there's very little. I mean, I think Joyce is going to talk about this in more detail, but there's not much evidence. So further research is definitely needed. And there's one sort of quite a big systematic review which showed mixed experiences in terms of patients and users. There's good evidence from having group cancer care reviews, which some people do. People seem to like those, but it's quite a big study, but just one. In terms of stratified follow-up, there's actually very good evidence, as I've just spoken about, in terms of patient satisfaction, adherence to guidelines, and the cost of doing this type of follow-up. All of that's very favourable. There's also very good evidence in terms of patient outcomes, in as much that we can find that it's just as effective as, at least just as effective as a more traditional follow-up, and in many cases better. So we can see that that's got a good evidence base. So that's where we are. Okay. So why is personalised care important? So we can see, as I've said, that traditional follow-up care and assessment models are not adequate for our patients, because it does result in people who have unmet physical functions, functional, psychosocial, and indeed financial needs that are just not met by the old system at all. So personalised care, when delivered well, is tailored to people's specific needs. So it's like what matters instead of what's the matter. And I think that's a big difference. It's like putting the emphasis on keeping people well rather than illness, and I think that's quite important for people, increasing numbers of patients who are living with cancer. And we can see from the next point that basically in the decade from 2018 down to 2028, we've got pretty much doubled the amount of people who are living with cancer, and that's happening right now. So we can see that using resources to do types of follow-ups on patients that aren't effective is a massive waste of money and resources. We can see, because it's shown, that stratified follow-up increases the proportion of people continuing to have surveillance tests. So if we leave it to people to take some responsibility for that, and that's a structured way of following up. Certainly people, the breast team at the Royal Barts, certainly Catherine would put an enormous amount of effort in making sure that people get mammogram reminders and that DEXA scans happen and those are reported back and the patient knows what the results are. And that's increased the proportion of people who have those tests. So that's pretty good. One of the aims, of course, is to increase self-advocacy in patients, but thus far the research doesn't seem to show that. it doesn't seem to show that people take on a massive amount of sort of responsibility. That was what we were hoping would start this process. But what that tells me is that people do rely on having a process. It doesn't need to be a process for people, a structure in which they can work, not just discharge back. And I think that we'd be quite at pains to say that people on stratified follow-ups are not discharged. What they're having is a different way of being followed. That makes sense. Okay, so the challenges that we've had, I'm sure you're pretty much aware of them. They're not easy. They're not an easy solution. When we first started doing this, it was like, certainly hospital doctors were very keen to take this on, saying, there'll be loads less work for us to have all this going on. In fact, that's not been the case. It's been less work for them, but not more work for other people. The other people concerned are CNSs in secondary care. There's a massive amount of work needed there. Putting in structures in order to make that happen. Investment in IT has been required, but also the fact that for those of you who work in primary care, I suspect many of you, it's not exactly been easy for you either. So you're going to have structures to support patients. When that happens, it's not like the patients disappear. There has to be a process for them to be. There is a follow-up going on, even though it's a bit looser than it necessarily was before. So it does move coordination of care from the doctor's clinic, largely in secondary care and anyway into clinical nurse specialist workloads and the teams that work with them. We wouldn't be able to work our stratified follow-up programs if it wasn't for investment in support workers. They're vital in the whole thing because they look after the administration and have some oversight over what happens with the data and how holistic needs assessments are provided for patients. All of that is pretty much looked after by support workers. And I think Catherine will tell you about that later on, about how that all works. Obviously, it needs a really reliable IT system to monitor the large numbers of patients who are no longer coming to 6 monthly yearly follow-ups. So in the old days, many people still do this, it's like you'd be guided by what their last outpatient appointment was. So as long as people make another outpatient appointment, that person will be monitored. But now we don't have that, so you have to have a system whereby people know who's on the programme, and that's been a real challenge. Not only because not all systems do that, but because systems don't always talk to each other. That's been one of the biggest challenges we've had to face. And in some places, some of these systems are rather clunky. They don't always work that really. Obviously, cancer care reviews putting pressure into primary care, which currently is really challenging because you're just as short staffed in primary care as we are in secondary care. So those resources and that kind of work wasn't there before, so that's new work for you. And I think the other thing to say is that, and I think it's a bit of a shame that the sort of funding's kind of run out for the cancer care facilitators because I think they've been successful, but we're only just starting to see that. It's taken 2.5, 3 years before we're starting to see that really bite and make a difference at the time when the funding's running out. So that's going to be a real challenge, I think, going on as we look forward to make sure how we keep that momentum going. And maybe Joyce will talk a little bit about that later on. She's pulling a little face at it now. She's adding that into the presentation. Okay, so let's talk a little bit about how we're doing. So we can see we're doing okay. I think if we look nationally, the Thames Valley is a little bit behind the curve. So what we should have had delivered last year, and I may emphasise that, is that everybody who is, so we should be providing 2 holistic needs assessments for all patients. One at the start of near to diagnosis and one towards the end, and when they're discharged onto either discharged or onto a stratified follow-up. We're quite,
So what's included in your holistic needs assessments?
What's included? Okay, it's quite a structured thing. So what we do is we have a whole range of physical, psychological, psychosocial needs, and what we do is we provide patients that can score themselves largely. So the way it works is a really good question. I'm quite passionate about this. I do holistic needs assessments myself, and I really like it. And what happens is we send basically a format normally by email or can be in person to the patient. they say what their concerns are, and then after that we get that back and then we meet with them and work out care plan. And that covers everything, actually, anything. I've had people troubled by caring for pets. I've had people troubled by, in certain categories group of patients, and people with menopausal symptoms, very high numbers of menopausal symptoms, because we're giving them endocrine treatments. So it covers a whole range of things, but there is nothing that's off the table in that assessment. Nothing. So it's our challenge is to try and provide a care plan that works. And indeed, care plan ongoing to primary care.
Can I just ask, sorry,
Yeah.
table, right?
Yeah.
It's number of patients. Is that out of how many?
We used to provide it. We're running at about.
Because we look quite low, but they're smaller than Rochers.
By you, wouldn't it?
RBH, sorry.
RBH, it's not all of our patients get. I think sort of if we look at, we used to provide percentages. We were doing at one point. We were doing percentages of those people who were treated. How many of them would then go on to have a holistic needs assessment? And we run at about 60-70% of patients. Because we don't actually, not that many people treated per month. It's not as high as you might think, but we're certainly not providing two, we're providing one at the minute, relatively successful. That's per quarter, remember?
Yeah.
It's not a category. And it does vary.
The percentages in this chart here, is that?
So that's the percentage of people who've had a HLA that have gone on to have a care plan, because not everybody takes a care plan. Most people do actually, but not everybody. Yeah, so some people get a holistic needs assessment offered, either don't fill it in, say don't want it, or they fill it in but say I don't want to care plan, don't want to do it. So that's representative. So we can see that generally speaking the fluctuations. Great Western actually do pretty well at providing people holistic needs assessment. They've often got problems with uploading their data, so that's why they've got a drop. It's largely about their reporting that's an issue, not necessarily around the numbers of holistic needs assessments. So basically, we're doing okay, but we could certainly do better. We should be delivering stratified follow-up, which I'll talk about in a minute, for everybody with a diagnosis of breast cancer, colorectal cancer, prostate cancer, and endometrial cancer. Most places are going to a minute. Most places are delivering 2 or 3 of those, but not all. And we should be doing that. And our target was to do that by last year, and we haven't done that. Basically. So that's one of our sort of targets for this year is get on that. And it is improving, but it's been quite slow. End of treatment summaries, a lot more patchy. We can see that books are not really able to, I don't know how many end of treatment support, end of treatment summaries they're able to provide, but certainly they've got trouble with reporting those, I'd say. Great Western, intermittently, pretty good. I think, once again, the problem with reporting. Oxford and ourselves, we provide relatively high numbers of end of treatment summaries, but certainly by no means all patients get those. There's pockets of really good practice, but then there are tumour sites which don't provide anything. For example, prostate cancer, at the minute we're not able to provide end of treatment summaries for people with a diagnosis of prostate cancer. It'd be really nice to do that. So it has been challenging. If we look at stratified follow-up protocols, we can see that books are delivering breast and prostate, Great Western are delivering breast, colorectal and endometrial cancer stratified follow-up. Oxford are doing breast, prostate and endometrial. We are providing currently breast and colorectal, endometrial will be coming online next month, so that'll be 3. So you can see we're doing, most trusts are doing 3 out of 4 of those. There's no trust that's doing all of them. So, in summary, I would say that the personalised care agenda is an important suite of interventions because they put this patient at the centre, what you do. They allow nurses and other healthcare professionals to use their skills to be actively involved in the planning. It's not like, it's something, I mean, I really like it because it for those of you who are quite long in the tooth like I am, it speaks to things like care planning processes, sort of like assessment, working together to do a care plan with the patient and then delivering that is part of my job. And I think that if nurses are not involved in that, I'd say, what are they doing that is relevant? So I often say that, really, to my colleagues, but you know, just stop saying it, that it's something that nurses certainly should be involved in. Actually, there are other trained and registered groups of staff that do holistic needs assessments and care planning and the treatment services, and where I work, they're regular. So, obviously it promotes collaboration and sharing of plans between secondary and primary care, and it addresses the needs of patients to become more involved in their own care, and it also addresses some of the resourcing issues we have as time goes on, with many people living with a cancer diagnosis, and making sure that they've got access to resources that are useful to them. I think that's pretty much it, I reckon. It is. There we go. So, any questions about all of that? Straight off the bat. Yes, what can I do for you?
I just wanted to, so if the patient has missed the holistic assessment,
Yes.
could they be, if we pick them up in the primary care,
Yes.
can we refer them, how we can get
Yes,
them back on the
you
track?
can do that.
To who do we refer to?
So it depends how far they are at treatment, I would say. Certainly,
A lot
if
of
you...
time they'll finish the treatment, they may have not thought about any of their needs while they were having the treatment. They're too focused on what's going on with their body and, you know, the treatment.
Patients can ask for a holistic needs assessment at any time.
Right.
Certainly the people, depends on who's got the skills to do it. Certainly in this area, I'm not sure how familiar sort of people in primary care, sort of like nurses in primary care or social prescribers or whatever, would have the skills to do that necessarily, or the training. But certainly if people want a holistic needs assessment and they're, say, a colorectal patient at Royal Berkshire, then we would provide that. You can speak to the colorectal team, they're ready to do that.
Just to expand this question, is there a telephone number or any means for patient to contact the clinic? Because quite often, okay, not quite often, but occasionally there is a care plan which flags up problems, but there is no follow-up.
Catherine, speak.
So this afternoon, Nikki Dan, who's our CNS team leader, is presenting. And I think she's going to talk to you about what the CNS teams do.
Okay.
So hold that question, because she'll have more things, and I think then she'll have the contact numbers and that kind of thing that you will need, absolutely.
But
so hold that thing. But
our patients all have contact.
so if anybody's on a stratified pathway, they will have the contact number of their CNS team, and I'm going to go through what we do with breast a little bit later, so I'll show you. And we are going to expand it out, but at the end of treatment summary, there is a quite clear central telephone number for breast patients to ring.
And you can do that as a...
And yes, no, so it's there in the GP, the letter goes, I'm doing a presentation now. The letter goes to the GP, it goes to the patient, it's the patient's letter and treatment summary, but it's copied to the GP surgery. And we tried to put SNOMED codes on them, just so that then it might make it easier, not to use it necessarily, because then it can be labelled in your documents area more. That's the reason we've put them in, and I'll explain that all later in the breast point. That's right.
There is the email address and contact numbers on your booklet, but I think the up-to-date one will be discussed later by Nikki Dan, the specialist nurse.
Yes.
Can I ask a question from secondary care approach?
Yeah, of course you can.
So like as foundation doctors, they're not normally kind of told about holistic needs assessment
Yeah.
and customized care plans. If someone's been diagnosed with sort of cancer, like a neurological cancer,
Yes.
relatively quickly in hospital,
Yes.
if you are making the diagnosis, say in ED, would it be best whilst breaking the bad news to start that process, or would it be sort of kind of flagging up these assessments for them? I haven't come across anybody having an holistic needs assessment or customized care plan.
If people are newly diagnosed, that might be quite tricky. We wouldn't necessarily have one, but it's certainly fine to flag that as something that's available to them. There's an interesting bit of research I was reading the other day actually, and that's around who is the person who's best to do holistic needs assessment. And it turns out it's not doctors. There are a whole range of reasons. It's sort of like doctors often have different relationships with their patients than other healthcare professionals. And the research that they did found they didn't bring much into the medical type of consultation you were doing, but it did bring quite a lot to like nursing time. So it's fine to flag that up as something that will become available to them. But what we tend to do is try and get people, once people have got a formal diagnosis, is then we provide them with holistic needs assessments. That's part of what everyone should get.
Like, based on just like case scenario, like
Yeah.
the patient was diagnosed sort of like a month earlier,
Yes.
came with symptoms of kind of progression which they weren't aware of.
Yeah.
There was no kind of care plan, obviously it's like mortality is high for this kind
Yes.
of cancer disorder. And because they're based across RPH and Oxford,
Yes.
it's really
Yes.
quite difficult for them to have one sort of clinician. And normally they relate to the person that breaks the bad news or takes that time to kind of deal with them as family. And in our training, we're obviously focusing on holistic kind of approach. And so, for example, like when you're in a gastro ward,
Yes.
we're generally dealing with people who get that kind of diagnosis that the treatment is not working or they need to be offered some C or something. Would it be worthwhile if they haven't had that or they haven't got a nurse specialist with them? And what we often find is they'll be between, say, gastro and oncology.
Yes.
Oncology doesn't
Yeah.
take them because they're not on their ward, and they're left with the gastro clinicians who don't necessarily have that.
So there's two things to say about that. So there's a number of responses, but firstly, acute oncology team will make sure that the patient's own CNS team, all our patients will have a CNS, all of them, without exception. So if people have a diagnosis of pancreatic cancer, it's a good example, then they will be plugged in to the upper GI CNS team. So acute oncology will help you signpost that person. And the other thing is that you can also phone that team direct and they will come and see the patient. So all of those people who are stuck in that position should have a way out of that. Yeah. In terms of holistic needs assessments, depending on where they are, they may or may not be aware of that they're available. Yeah. If people go on through their cancer pathway, they will become more aware.
I was wondering if it was a system like it adds up, then you,
On EPR,
yeah,
you'll be able to see if people have a holistic needs assessment.
we don't get training in terms of like where you find it or.
Yeah, I bet you don't. They're really hard to find as well. They're not easy to find. So, but if you look at oncology notes, you will find that some of those will be holistic needs. Some people have 5 or 6 of them. And some of those are really helpful to you as a doctor. Yeah.
Just
One more
last
question. I love questions anyway. 2 questions. Can I do 2?
Okay,
Yeah.
okay.
What we're doing in 3 months, that's okay with me. That's really the first time I really care that
Yeah.
we still need this.
Yeah.
Into our form, high level of being needed. When would you say is the best time for that intervention?
What, for the H&A or for the cancer care?
H&A.
For the H&A, well, the original research said that you should provide them several times during the cancer pathway. That's been really hard to deliver, actually. So what I think, and what my experience is, certainly just before they are discharged and leaving the hospital to go on either stratified follow-up or discharge is great. That's vital. I would say that's really important. And ideally towards the beginning of the pathway too. Although depending on the speciality, people tend to be obsessed by the thing that's happening next. For example, Catherine's patients, if they're going to have surgery, might be really worried about surgery and very little else, for example. So sometimes that doesn't work well, sometimes it works well. One more and then I'll stop.
I just wanted to ask where end of life care discussions come into the assessments. Is that patient-led or is there a different?
Okay, that's a really interesting, and maybe we could talk about that later because that's quite an in-depth conversation. But end of life people, what we try and do increasingly in oncology is try to provide earlier palliative care type of discussions. Certainly with people with metastatic disease, they might well form part of their holistic needs assessment, and that's fine. For people who are then become progressively more end-of-life care, or people who have incurable cancer, then we probably have to do other things in order to support them. But there's a whole suite of things that are available. I'm done.
Thank you, Mark. Thank you. That was really good.